with a shot. Vincent Lane with a goal. Riley Johnson. Oh, Riley Johnson found a space. No foul that time. Archer with a shot. Michael Archer with a goal.
We just need more offense.
And you need to move. They will get our goal.
Shot goal. Saved by Damon. Corner kick for San Jose.
There it is.
A goal by number 6, Michael Graydon. Damon over to Engel. Going for a big shot. Far post. That is in for Engel.
Riley Johnson pushing. Moises Rojas not afraid of the contact. Cunningham. Marshfield with a goal.
That's the way you play, isn't it?
Breakthrough. Oh, and he follows it up. What a goal.
You can't tell me I'm not strong.
You can't tell me I'm not fierce.
You can't tell me I'm not bold.
You can't tell me not to fight.
I dare you to underestimate me.
I dare you to challenge me.
I dare you to stop me.
I dare you to tell me no.
I am undaunted by doubt.
I'm fearless and unafraid.
I am more than what you see.
I am beautiful because I am.
I am a champion.
I am a fighter.
I am a leader.
I am an athlete.
I am powerful.
I'm confident.
I am defiant.
I am unbreakable.
I am undefeated.
I am not meant for the sidelines. I am meant for victory.
Hello. Hi everyone, welcome back. It's a pleasure to be with you. And today the speaker will be Julie Fressel. Sorry. Before welcome you, I want to mention to this is not an official clinic. It's only an update or introduction so that we are prepared to back to the core. Also, let's you know that at 2:30 p.m. will we have a 10-minute break. Okay. Now, welcome, Julie. Thank you for your time. For me, it's a pleasure to have you.
Thank you. All right, let me start this here.
Perfect.
Okay. So yeah, I am Julie Fressel. I am a PT, a physical therapist. I live in Indiana, in the USA. I have worked as a physical therapist since 2008. I work at a rehab hospital in Indiana. If you follow some of the U.S. Powerchair football, I work at RHI, which we have Sudden Impact and Inferno. So that was kind of how I got started with adaptive sports, is just knowing some of the adaptive sports at our hospital and then branching out from there. So I have been an international Powerchair football classifier since the start in 2010. We met up in Vancouver and have been doing this ever since. So, you know, I don't know, 3 World Cups maybe, some of the European Cups and the America's Cup last year. And then between JP and I, he and I are two of the US classifiers. We're the ones who are trying to start working on forming the US classification. So, I mean, COVID has kind of waylaid that, but it is in the works. So hopefully soon. So that's why this is a great way to kind of get this started, is that eventually this will be coming to the US as well. A few of these are going to be a repeat of last week. These very first ones to kind of give you a refresher. So why classification? Basically, it's to minimize the impact of impairment on the outcome of the competition. So that way, those who are successful do so based on their ability and their skill, not their level of impairment. So to achieve this, the athletes are evaluated and put into sport classes according to their extent of activity limitations. So that way, it's not based on their impairment as the reason they win, but their skill. It ensures strategies, skills, and talents of the athletes and the team to determine their success, instead of just who has the team with this level of impairment. So, and as Hannah was saying last week, there's PF1, PF2, and ineligible. So the PF1 has the most level of impairment, PF2 is lesser level of impairment, and then ineligible is too high of a level, lesser of an impairment level. So in FITFA sanctioned events, teams have at least 2 PF1 players on the court at all times. I know Hannah was explaining that to you last time. So you can have, all 4 PF1s, but it have to have at least 2 PF1 players on the court at all times. So this is the same as last time. It's from the Paralympics website. So what we look at, does the athlete have an eligible impairment for this sport? Then does their eligible impairment meet the minimum impairment criteria? These are kind of basic things that the International Paralympic Committee is looking for. And which sport class then should they be put into based on the extent to which they're able to execute the specific tasks and activities fundamental to the sport. That's their wording. So basically, are they eligible, and what group should they be put into is the general gist of everything. So originally, since the beginning from 2010 into 2018, there were these 5 groups: amputees, neurological, which then included the traumatic brain injuries, strokes, cerebral palsy, and then orthopedic. So that was arthrogryposis, arthritis, osteogenesis imperfecta, and dwarfism. Myopathies then were the next one. So all the Duchenne, so any muscular dystrophy, SMA, MS, multiple sclerosis. And then spinal cord injury was the last group. So that would include the spinal cord injuries, polio, and Guillain-Barré. So the non-eligibles were reduced limb length, visual impairment, and intellectual impairment. We weren't allowed to base somebody's class based on those. However, reduced limb length is, you have to have 3 of 4 limbs affected. So if you only have 2 limbs affected, that gets you in this non-eligible. So this is kind of a reduced limb length is yes and no, because you're actually, if you have 3 out of 4 having a reduced limb length, whether it's traumatic or congenital, then you are eligible. So this was how we did this for a long time. This is also, I believe, what is in the, it's in the current guidebook, classification book that I believe Hannah sent out last time. However, to comply with the IPC, because we're trying to become a Paralympic sport, Starting January of 2019, Power Soccer switched to the following groups to be, because this is the standard for all sports for the IPC. So who's in what group? The impaired muscle power is the largest group. So it has all the muscular dystrophies, spinal cord injuries, some of the cerebral palsy, and then, but cerebral palsy kind of has 4 classes, 4 different groups. So then the limb deficiency, so that's again the 3 out of 4 still. Short stature is by itself. And then the 3, the hypertonia, ataxia, and athetosis are all ones that we can group those who are more of the cerebral palsy, the CVAs, strokes, and the traumatic brain injuries. They kind of get each one of these different categories. Some people are in more than one. And so these are based on just what level of, they might have a certain type of cerebral palsy. And then the impaired range of motion is the arthrogryposis, the arthritis. So our rule book is getting looked at by the IPC right now. So it's being adapted. So it's coming soon. By the next World Cup, it will be instated. And so when we're looking at people to be classified, to be eligible to be in the World Cup, this is what we're basing it on, is this classification group, because this is how it's going to be for those future ones. So we're kind of in that in between time right now, but we have to go by the old one. However, knowing that it is coming for the next World Cup, and maybe depending on when it gets approved, maybe for the next European and America's Cups, and all of the country cups, then we might be switching to this one then. So know that this is in the works. So again, evaluation process. The medical assessments are first, then technical, then observation. So Hannah talked about the technical assessments and the fact that then we observe them at the end to make sure that everything agrees with what we saw on the medical and the technical, or the medical and the technical side. And then they get their class after that. So do you have a question?
Hi, hello, Julie. My name is Mariana. May I ask you a question now, or do you want me to wait till the end of the?
You can ask now, but if I'm going to cover it later, I'll tell you that. How's that?
Okay, great, thanks. Well, I wanted to ask you about the non-eligible with the current classification. I mean, the one related to sensory impairment. Are you taking them into account, or?
As far as if you can't feel your legs, but they could still be working? I mean, you could still have motion, but you can't feel them, or?
No, more generally, for instance, visual impairment, as you were saying, or deaf people, or I don't know, also intellectual impairment. Are they still non-eligible? That's my question.
Oh, yes. So you can compete if you have an intellectual impairment. It is just not something that we base your classification on.
Okay, thank you.
Yeah. Same thing with visual. You're allowed to compete if you can safely drive a power chair and you have a little bit of visual deficits, you can still compete. But the hardest part is we just can't take that into account when we're classifying someone.
Julie?
Uh-huh.
Can I just hopefully, correct me if I'm wrong, but clarify that they also have to have one of those other physical impairments. They can't just be visually impaired or deaf. They have to also have CP or muscular dystrophy or something like that. Just to clarify.
Correct. Yeah. Yes.
Sorry.
Oh, yeah. Thank you. Yes, definitely. Okay, so we get to go over the medical assessment. So again, this was the same one you saw before. The interview is first. You go over the diagnoses. You go over the medications, all that basic stuff. Then we go over the equipment. And then right now we're gonna break it down into the rest of that. So we already talked about those first two, and now we're going to talk about the rest. So that's kind of the part for today. So manual muscle test is the one that we use. That's kind of a standard for anybody who's a physio or a occupational therapist or a doctor. So this is the basic one that we use. Oh, sorry, that picture kind of cut the last one off. So 0 being a total lack of voluntary contraction, nothing is sending the signal down. 1 is a faint contraction, so you might feel a little bit of a flicker of the muscle happening, but nothing actually is moving. 2 is through a full range of motion, but when gravity is eliminated. So I don't know if you can see my picture as well. So if I'm moving my arm and I'm straightening it out and bending it, but I have it up, so I don't know if you can see me, but if it's going again, not against gravity, then that's a 2. So 3 means you're going against gravity. So that would be having your arm down at your side and bringing your hand up towards your mouth. Does that make sense? I'm hoping it does. So that would be more a 3. 4 would be with a little bit of resistance, and then 5 is full contraction. You know, there's nothing is going to push against you. In the therapy realm, we use pluses and minuses, but it just gets a little bit tricky, and we don't need to be as specific on that when we're doing these. So that's definitely something you have to think about when you're used to doing pluses and minuses as well, but you have to just break it down to 0 to 5. We're trying to make this as easy as possible so that you can like, that's why we have only 1s and 2s on classification. 0 to 5, we're not trying to make this too complicated. We're trying to make it as easy as possible, so that way, when you're doing research-wise, a 2+ is about the same as a 3-. So we're trying to make this so that there's consistency between all people to eliminate the amount of discrepancies there might be. So that's the basic one for us. I'm throwing in PF1 and PF2 throughout this whole thing to kind of let you see how it goes together. So again, PF1, PF2, scores based on function and how the impairment affects performance. So we're looking at positional recovery, like can you recover from, you fall to the side, are you able to get back up, or you need somebody to help you get back up in your chair and situated. Reflex reactions. So that's if something happens, then you're going to immediately be able to recover, or the startle reflex is one of those things that happens. The whistle blows, or somebody has one of those loud air horns, and that throws somebody out of the game because their arm flies off their joystick. So that's one of the other things as well. Visual lag, which we'll talk about later, and then increased tone with effort. So you might not see this when we're doing the bench stuff where you're seated in that area. However, we push them to try and get them to go farther and faster. And when you do that, sometimes their tone will increase as they go. Same thing with when you're in the game, you'll definitely see this increased tone with effort. So we want to make sure we're seeing that as a picture, as opposed to somebody might be really relaxed, sitting in there getting their stuff done with us, and then they get out on the court and look completely different. So that's why the observation part is important as well. So first it's head and neck. So you're checking rotation. The biggest thing here is a stable, independent head. So can they hold their head off the headrest, or can they keep their head against the headrest while they're, you know, moving around, or do they need the side pieces or the strapping on their head, something to keep their head in place? Then that's basically the biggest one here. So these PF1, PF2s are not a clear cut. I mean, everything is a little bit different based on your diagnosis, but these are kind of generalities. Okay, so don't take this to, just because Julie said PF1 here, then that means that's set in stone. Okay, but PF1, difficulty maintaining your head with the impact, must use your headrest. And then when you've got this headrest back here, you can't turn your head very well, and your visual range behind you is limited. So you really have to then turn your chair in order to be able to have the ball in front of you, which might just be, it might take you out of the play because you can't see back there. So you have to turn your whole chair, and you might not be able to get the ball as well. PF2 on the manual muscle test would be a 3 out of 5 or better, meaning that if you're against gravity and then you have to come back up, you can, and able to sustain impact without losing control. Trunk control. This is a big one, but it also depends on the diagnosis. So this is your basic postural control. Can you, in the beginning, can you just scoot your bottom forward and sit yourself away from your backrest? And can you hold yourself there? So that's, you know, number one, see if they can do that. Then we check all directions. So flexion, bending forward, extension, coming back up to the back of the chair, side bending. So it's, you know, reaching down to your side and then coming back up, and then rotation. So can you twist at all? So this is when we're asking people, when that history is important of, do you have a rod that goes from your neck all the way down to your tailbone? And if so, some of this isn't going to come in play. And so that's what we want to know. I'm not going to force someone to do motions that there's no possible way it's going to happen, because that's not, I mean, that's not what they don't want to, I don't want them to come out of there with a bad experience with having classification. So PF1 in general, moderate to poor trunk control. They need that chair to support them in place. Difficulty or fail to recover from movements. So again, if they get knocked outside of their backrest, can they recover back up? And they can be, I mean, level 2, they can be delayed, but they're usually able to recover. PF1, you're going to need somebody else to probably push you back up, or you're going to need to use your arms or something in order to get you back into place. PF1 is also where reflexes are stronger than the movements. So, you know, you have someone with a more severe cerebral palsy, and they can control it at some points in time, but then, you know, their ATNR kicks in and they're way back or way forward or side, or I mean, I would say typically back, but it takes them out of their proper position. PF2, able to recover, but they can be delayed. So they may have some reflex patterns throughout, and that's okay. It just matters how much and what level that would take them out of the game or out of the actual play that happens. Decreased range for orthopedics, but they're stable. And then the spinal cords and myopathies, both are going to have limited trunk use. I mean, that's the nature of somebody who has quadriplegia or even a high paraplegia. They can't, I mean, they're not going to, in a spinal cord injury, they're not going to have trunk control. And we know that, but how much, then it takes more into account how much arm function. So that's why you look at all of these different pieces together and you put it as a collective whole. You don't just say everything's a 2, but this one spot is a 1, and so they're a 1. You kind of look at more of the general person as a whole. Arms and legs. So we will check both sides, typically for the sole reason that the other arm might be their supporting arm to keep them up in their chair. So typically it's mostly the driving arm. However, if they're one that braces themselves with their other arm when they're going side to side, or they really push with their legs, or there's someone who actually can stand and take a few steps, but they're not a functional walker, that's where some of the legs would come into play, as well as if there's someone who actually drives with their foot as opposed to their arms. That's where we would say arms and legs both come in. So manual muscle test, main groups, biceps and triceps. So that's your upper arm. So being able to bend and flex your elbow, or bend and flex are the same. Bend and extend your elbow. And then wrist, whether you can bring that up and down. Same thing with fingers, like how much grip you have. And if your fingers have the ability to do a full grasp, or, you know, if you're only doing a, I don't know what you call this, like a more of a little hand talking, not where all of your joints are extended, except you have that ability to flex in your hand. So try not to get too technical. So that would be where fingers would come into play. If somebody uses a microprocessor, so they're only using that little tiny bit with their fingers, then that's, you know, where we're looking at a lot of the finger joints. And then shoulders. So someone will have to recover by bringing their whole arm back up by using their shoulder. Or they might drive more with their shoulder. If the bottom half of their arm is kind of secured in, then they're using all their shoulder muscles to drive. So basically we're doing almost all of the parts of the arms, because we know that with driving your power chair, that's where it happens. So we also look at contractures. So that is where a joint just won't move, especially like an arthrogryposis. You know, they might have just a little bit of range, and that's all they've got. And so you might be really strong, but if you can only move, you know, like this much movement, then that makes a difference as well. So we just want to see, you know, we're not going to be super specific and measure and say, oh, that is exactly 87 degrees. We're kind of grossly do it. You've only got 20, maybe 30 minutes to get this whole assessment done. So it's as specific as you can, but then you're not completely specific that, you know, it's that fine of a detail. The ability to bring the arm back onto the joystick after impact is why we are looking at those manual muscle group for the biceps and the wrist. And some people are completely strapped on, and that's good. I mean, that's what they probably need. That's what is advised. But if they are able to bring that arm back on, they're going to have a quick recovery. Then we want to see that too. Also, that what I said before of why we check both is that ability to stabilize yourself with the other arm in your chair. Coordination and spasticity. This one is it's specific to the diagnosis. So if you have cerebral palsy, a traumatic brain injury, MS, any of the ataxias or dystonias, this is going to be a big one, as opposed to someone who has maybe a Duchenne's who doesn't have as much spasticity involvement, but coordination could be decreased. So I am personally more in my everyday job, I use the modified Ashworth scale. That's what the MAS is. We're using the Australian spasticity scale, which is pretty similar, but just know that that's the one that we use. Biceps is the one that we really look for spasticity in. So if you don't know what spasticity is, it's extra muscle tone that you can't control. So it's that extra muscle firing that, you know, there's going to be a catch when you're trying to move your arm quickly one way or the other, then that arm is going to catch and then can go on, or it might just not be able to. So a 0 being no catch, that would be no extra muscle tone, all the way up to a 4 where it's such high tone that it is fixed. And then, yeah, triceps, wrist also involved, but biceps would be that main one. So that's just that ability to flex at your elbow. The Sarah scale for ataxia is another one that we won't do the whole thing. We don't have that kind of time, but it's more your basics of what we are looking at in general. So this fine motor coordination, gross motor coordination, those are all part of this scale. So being able to like do a piano, or trying to go through your fingers, touching your thumb to each finger, or being able to flip your hand over and back, all of that is included in that ataxia scale. Same thing with touching if you can touch your chest and then touch your finger to somebody else's finger or a different object, and go back and forth quickly to different spots. That's all checking that coordination. It helps us to know how, driving wise, if you can just control that joystick well. And again, the startle reflex that I talked about before, this is a big one for those with cerebral palsy or a TBI, a traumatic brain injury, where that would really take it out of the game. So if we're blowing our whistle super hard, this shows up more when we're doing the technical assessment, because then we're going to blow that whistle to see how much they can react and get back on, or if it just takes them completely out of the play. Delayed responses. So, you know, you ask somebody to do something, but it takes them a couple seconds to respond. That's another reason that it would take you out of a play. ATNR is a reflex. And then synergy patterns. So, you know, every time you bring your head up, then your arm comes up at the same time. Something more along those lines. So I hope those make sense. Man, I'm flying today. Okay, so the other one is that visual lag. So this is the one that Hannah was talking about last time, of you keep the ball back behind them, and there's a red square, a blue triangle, or a green circle. They're on different parts of the ball. You put it at different angles behind them, and then you see what they can see. So we use an angle finder or a goniometer. So you kind of see this on my screen. We're just measuring the angle behind them. Okay, so 110 to 130 degrees of behind them they can't see has a visual difficulty. So if here's about 116. I don't know if you can see this very well, but this would be the angle behind me that I cannot see without. So when you're doing this, you're just telling them, okay, look back, and they're turning and looking behind them and come back. They're not really turning a whole body. It's a quick movement that they would do in a game. So if they have to struggle and they're cranking themselves to get around, and then they can finally see that ball behind them, they're not going to do that in a game. I mean, that's not functional. So you're just saying, okay, look, and then they look back and come forward, blue square. Okay, look, and then look back, red triangle. And so that's how you're checking. You do one side and then you do the other side, and you put little discs on the ground and you measure that angle. So 130 degrees or greater is that PF1 range. Okay, so that's when you you know that they have a more visual deficit, and that puts them in the more PF1. So this is where visual difficulties come into play. Is one, it could be the headrest. They might have one of those headrests that goes way out to the side and they just can't see anything back there. Or they don't have peripheral vision for some reason. So they don't have that ability to look out to the side. They have more of like a, if you had blinders on and you have tunnel vision and you can only see straight ahead, they might only have that zone. So then again, you have to turn your chair to get all the way to where you need to see. And that's going to take you and your chair out of the game. And then after that, we do all the technical stuff. So I'm super fast. Instead of taking a long time, that's the basics. So what questions do you have?
Hello everybody. First of all, my question is, what's the range for a PF2 again, please?
So you can have 0 and still be a PF2. I mean, you could be able to see completely behind you to both sides and still be a PF2, but that would go all the way up to that 130 degrees, give or take some degrees based on the other aspects. So it's harder to say PF2 because it's not the only thing we look at, but if you're above 130, it's pretty good bet that you're going to be a PF1.
Okay, thank you.
Help?
Yes, thank you.
Okay.
Well, now it's clear.
Anything else?
Okay. Thank you, Julie. It's very well.
Yeah.
Clinic. You was very well teacher. Question? I think in the chat.
Julie?
You should call.
Yes. See where I can raise my hand, but I have a. Julie, could you explain to people? This is Barb. Could you explain to people how often somebody might get classified and what the process is for that?
Yeah. So everyone would get classified on their first BITFA sanctioned event, so a first official event, or in your country, if your country says, everyone must be classified, which should be the way that it's going, everyone will get classified their very first time that they're on the court. So then you have to get at least 2 times of being the same number to be declared as someone who is going to be consistently that number. So then we don't have to classify them anymore. So if you're a 1 and you stay a 1, the next time you get classed, we're not going to take you through this process again in that same level. So if you're classified on a national level by national classifiers, then when you go to America's Cup or the World Cup or the European Cup, when there's a whole international group, then they will need to make sure you have an international class. So it gets kind of tricky there. But if you went to the World Cup or America's Cup and you've been classed twice, you have an international number, that pretty much trumps a national level, and you can stick with that number. If you are a PF2 and you have a progressive disease, then, or progressive diagnosis, you might be going down to a 1 eventually. So you have then, you can keep getting classed each time, or you can stick with a 2, and then if you feel like you're going down to a 1 and you want reclassed, you can do so. If you're a 2 though, and you don't have one that's progressive, then, and you stay a 2 the next time, then we're going to consider that your permanent class, and you won't get classed again unless there's some other thing that happened that would make you into a different class. I hope, is that clear as mud, maybe?
Thank you,
So
Julie.
we're trying not to class everybody every single time. 2 of them and done if you're consistent.
Yeah, it's okay. More question? Julie, you could read the chat.
That's what I'm trying to read about. Let's see, I know if it, so that's what we're there for. If we don't, you get time ahead of time and you hope to research, or you can ask them about it. But typically, most of the things that we see, the medical classifier should know what they are. IPC is trying to switch to numbers based. So instead of on a manual muscle test, giving you a 0 through 5, they're trying to get to a strength score that's based on like how much you can pull against this resistance thing. So like a luggage scale, where it measures the amount of force that you are pulling, that tells whether you can take your luggage on the airplane or not. They're trying to get to those kind of numbers. We're not there yet. We're doing research right now on getting those numbers down. So I know that is a Paralympic guideline they're trying to push everybody away from, but manual muscle tests have been standard for years. Same thing with like trunk rotation. So, you know, we're trialing right now the point of putting a ruler from like a tape measure from your shoulder, your bone down to your opposite hip bone, and then measuring that number. So we're trying to get more objective data, and that's where we're going right now, is that IPC needs research. And so we're working, especially JP from the US is working on trying to get numbers down. So this is all very cut and dry of you have these numbers, this total adds up to this, so therefore you're a 1 or therefore you're a 2. Typically all sports classification has not been that number based, that specific, but that's kind of why you have a panel, is so that you have more than one person agreeing with this. It takes the subjectivity out of it, because you're testing all these different measures to try and make it as non-subjective as possible. Does that help, Chris?
Yeah, it did. Thanks, Julie.
So, is any question? No more?
Short day today.
Yeah.
And Hannah said next week is practice. So make sure that if you want to try and practice, that you have somebody that you commandeered, that you recruited to be with you to try and do some practice, like sit them down in any type of chair if you don't have someone that you know of that is in a power chair with you. And that way we can do some practice. But again, this isn't making an official classifier because we don't have all these little nuances of being able to see, you know, practice everything, putting somebody in a chair, watching people on the court, all of that. So all those little nuances are still things that we'll have to then practice. But this at least gives you that basis, so that way when we're ready to get back out on the court again, we can start doing all the classification again and then get people going.
Okay. Hannah is not here today. She's busy. If you don't have any more question for Julie, we wrap up today's presentation. I don't know.
Thank you, Julie.
Welcome.
No more question? Nothing? Okay. Thank you very much. It's all for today. Is the next Saturday, the practice for Hannah. It's okay?
All right.
Thank you,
Thanks,
Julie. I'm pleasure for me have today here. It's very clear your presentation. Thank you very much.
Perfect. Thanks. Bye, guys.
Bye. Thank you.
Bye bye. Thank you. Bye bye, Barb. Bye bye, Donald. Thank you all. The next see you next Saturday. Bye bye.
Bye bye. Thanks, Pablo.